Hello, everyone. Good afternoon, good evening, and good night, wherever you are. Welcome to the webinar for the WFNS Neuroanatomy Committee. And this time, the Neuroanatomy Committee, we are having the presentation of Anatomy of Approaches. And this is the second webinar titled The Applied Neuroanatomy for Cortical and Subcortical Lesions. Now, we have here today several great speakers, Dr. Chen Li, Dr. Eduardo Ribas, and Dr. Pablo González-López. And to start off with the first presentation, we call upon Dr. Chen Li for the first speaker. Please, Dr. Chen Li, the time is yours.
Hi. Hello?
Oh, yes, we can hear you.
Okay. I share the screen now.
Yes, please.
Okay, can you see the screen?
Yes, very good. We can see it.
Yes, we can see.
Okay. Yes, hi, everyone. I'm Chen Li from the Huashan Hospital in Fudan University, Shanghai, and it's my honor to give this speech. And today I will be presenting the microsurgical anatomy of the fiber tract and the vascular structure lateral to the internal capsule. Okay. As you see, since 2019, our lab has organized an annual microsurgical dissection workshop on cerebral water metal fiber tract. This image shows the first meeting in 2019, and which was attended by many leading experts in the field of neurosurgery. And this is the second annual meeting. And the third one is the fourth. Yes, it's fifth. And it's 2024. And it's just last year. Yeah. Yes, I also had the privilege of participating in the related anatomical meeting held during the Dubai in 2025. And this is the picture with Ribas and the first. Okay, some work also has published in GS. Yes. And this is our lab. Yeah, you can see the many microscopes here and many instruments. Okay. For neurosurgeons, neuroanatomy is the foundation of our discipline. In the OR, a neurosurgeon's control of surgery is much like of an excellent general commanding a battlefield. Yes, you must maintain a comprehensive view of all the overall situation, which also mastering every cortical detail. And the study of anatomy is precisely what provides this capability. And without a solid understanding of neuroanatomy, a surgeon may become unprepared and become overwhelmed when facing complex intraoperative situations. As you see, the dual matter is incised and reflected to both the cerebral hemisphere here, and the important cranial anatomical landmarks are preserved. Although neural navigation has developed rapidly, but a solid understanding of these fundamental anatomical landmarks remains essential for our neurosurgeons, especially the young neurosurgeons. And first, we expose the entire lateral surface of the lateral cerebral hemisphere here. We can see this is central circles and many landmarks, and I think you have recognized it. Okay, let's go first. When peeling the green matter and the U fibers, the underlying acute fasciculus was exposed. And this is the one. With the superior longitudinal fasciculus 2 located above and SF3 located below. The aqueous fasciculus connects the Broca's area in the frontal lobe with Wernicke's area in the temporal lobe. Okay, after dissecting, and this way we expose the insula. The insula is encircled by the limiting circles, and separated from the frontal, parietal, and the temporal opercular by the anterior, superior, and inferior lymphing suci. We surrounded the insula in a triangle shape. Removing the insular cortex exposes the extreme capsule. You can see this is the extreme capsule, which connects the adjacent insular gyri horizontally and projects vertically, and deep to the limiting inside to the opercular areas. And we can see what it is. This is the middle longitudinal fasciculi, and the blue one is the inferior longitudinal fasciculi. And the MDLF, which is middle longitudinal fasciculi, lies within the superior temporal gyrus, originates from the temporal pole, and passes through the superior temporal gyrus to reach the inferior orbital parietal lobe, especially the angular gyrus. And the inferior longitudinal fasciculus connects the temporal pole to the dorsolateral occipital cortex without reaching the calcareous cortex, and the inferior longitudinal fasciculus within the inferior temporal gyrus. And then we're removing the extreme capsule, exposes claustrum, just here is gray matter, and the external capsule. The claustrum is a thin collection of gray matter between the extreme capsule laterally and the external capsule medially. Both the external capsule and extreme claustrum have two parts. Both have ventral and dorsal parts. And the dorsal external capsule is formed by cortical projection fibers, which connects the claustrum and the cortex between the supplementary motor area anteriorly and the posterior part of parietal lobe posteriorly. The ventral external capsule is formed by I4 and onsilus fasciculus below. You can see this is I4. Yes. I4 is a frontal occipital association fiber pathway. We can see connects the middle and inferior frontal gyri to the posterior part of the parietal and occipital lobes. And the yellow one is onsilus fasciculus UF. Is a frontal temporal association fiber pathway, connects the temporal pole to the lateral orbital frontal area through its dorsolateral branch, and the media orbitofrontal and septal area through its ventral media branch. And then media to the external capsule is the lentiform nucleus, which formed by the putamen laterally, this putamen, and the globus pallidus medially. Inside one is globus pallidus. Removing the putamen, we can expose the globus pallidus and the anterior commissure. This is the anterior commissure here. The globus pallidus sits just behind the anterior commissure and involves in the regulation of volumetry movement. The anterior commissure crosses the midline. You can see here across the midline at the base of the putamen to connect the orbitofrontal, occipital, and temporal lobes. Yes, we have some branches just to the temporal, to the occipital lobes, and also connects the amygdala. And in this picture, we can see the lateral ventricle is exposed, including the body, the atrium, and the occipital horn. The lateral wall of the lateral ventricle in temporal lobe here is composed of several structures, which are arranged from medial to lateral. We have the abdomen, the tapetum, the posterior limb of internal capsule, which containing the optical radiations, followed by the inferior frontal occipital fasciculus with I4 and the aqueous fasciculus with the AF. This is optical radiations. And we expose the whole of the lateral ventricle here. and the interhemispheric fissure is exposed. And from this one, the entire interhemispheric fissure is now exposed. Okay, let's go the vascular. The major vascular structures lateral to the intercapsule will be introduced. And the left cerebral hemisphere was exposed, revealing the lateral surface of the brain, which is covered by lumbar arteries and veins. The main arteries supplying the lateral surface, including the MCA, ACA, and the PCA. The lateral surface of the brain is strained by a network of superficial veins. The superior sagittal sinus groups consist of veins draining into the superior sinus, including the anterior, middle, and the posterior frontal veins, as well as presentral veins, responsible for draining the medial and lateral venous blood from the frontal, parietal, and opposite lobes. The superior parietal sinus group includes superficial veins of the lateral fissure and occasionally deep veins of lateral fissure, responsible for draining venous blood from the frontal, parietal, and temporal lobes and adjacent to the lateral fissure. The tentorial group includes the veins from the basal parts of the temporal and opposite lobe, such as the vein of Labbé, and there are communications between the draining veins, preparing for possible comprehensive needs in the future. And just like we peeling away the gray matter and U fibers, and we can see the IAF articular fasciculus, superior longitudinal fasciculus 2, and superior longitudinal fasciculus 3. The veins on the apiculum of the lateral fissure were dissected, exposing the vasculature of the insula. The vasculature of the surface of insular cortex consists of branches of the M2 segment of the MCA, which supplies both the gray matter of the insular cortex and the extreme capsule. The main trunk of the M2 segment follows the operculum, which is M3 segment, emerging from the lateral fissure to form the M4 segment. We can see this is enlarged view. Upon dissecting the M2 segment, the insular cortex, extreme capsule, and the middle longitudinal fasciculus, the claustrum, and the external capsule are revealed. Just this claustrum with the gray matter and external capsule have dorsal and the ventral part. Dissecting the anterior part of external capsule, we can expose the putamen just inside the external capsule here. The lateral surface of the putamen is revealed, and the draining veins can be seen on its surface, which drain the external capsule area. And this one, we can see the lenticular striate artery, LSA, emerge from the inferior part of the putamen. And by dissecting along these arteries in the anterior part of the putamen, their course is revealed. And we can see the first is the surface. Two LSAs are identified, each accompanied by a lenticular vein, LSV, which streams inferiorly. And further dissection of the superficial layers of putamen reveals three SS, and accompanied by LSV. We can see here. We can see each lenticular striate artery, which is LSA, is accompanied by a responding of lenticular striate veins, which is LSV. And during our putamen and especially insular surgery, if hemorrhage occurs here, it may be caused not only by arterial bleeding, but also by venous bleeding, which can be distinguished by the bleeding pattern and volume. If venous bleeding is identified, local compression can be used to stop the bleeding, and the coagulation can be avoided to minimize the functional damage. And it's also confirmed that there is no communication between the LSAs and the insular artery. The external capsule thus serves as the boundary between the blood supply of the LSAs and the insular arteries. The LSAs is an essential landmark during insular-related art surgeries, indicating that the surgeon has crossed the external capsule and reached the putamen. And when performing the insular surgery, this anatomic mark is crucial for identifying the putamen, as the internal capsule is located just medial to the putamen. Avoiding injury to the internal capsule is essential for preserving the associated neurological functions. In related clinical surgical studies, it has been noted that identifying the LSAs helps protect them, as damage to the LSAs may lead to terrible outcomes. And we remove the entire putamen and the global spiders to reveal the whole view of the LSAs and the LSVs. We can see the SAs is originating from the M1 segment, media via the I4 and the UF, which is inferior frontal obstetric fasciculus and the onciliary fasciculus. Media to the putamen and the global spiders is the internal capsule, which is RC. Just here is internal capsule. The LSAs originate from the M1 segment of the MCA, which 18% arising from the pre-bifurcation part of the M1, and the other originates from the post-bifurcation. The recurrent artery of Hubel arises from the A1 or A2 segment of the SA. After its origin, it travels back towards the anterior perforated substance. The LSA penetrates the anterior perforated substance to supply the basal ganglia, cortex nucleus, and internal capsule. And this is corresponding schematic illustration. Okay, in this picture, we remove the SSVs to just we can hear the Cox point is widely used in clinical procedures such as the third ventriculostomy, lateral ventricle puncture, basal ganglia hemorrhage drainage, and the DBS, which established clinical efficiency and safety. And we simulated the entry of the Cox point here. The point was localized on the left cerebral surface, and our observation shows that this point is positioned anterior to the precentral sulcus as a safe distance from the superior sagittal sinus. Additionally, there are no major draining veins underneath, and the arterial branches are minor, thus minimizing the risk of injury. The structure traversed by these puncture routes to reach the target surgical region includes the posterior parts of the middle frontal gyrus, both cortical green and white matter, the SF3, the external capsule, and eventually here, basal ganglia here. The trajectory lies anterior to the precentral gyrus and anterior to the AF and the lateral to the internal capsule. If the puncture advances medially with the basal ganglia, it passes through the posterior middle frontal gyrus and the corona radiata to reach the media basal ganglia. This study confirms that puncturing through the Cox point to process the basal ganglia and the related regions may minimize damage to the fibers, such as to the arterius fasciculus and in the capsule, and preserving the motor and language functions. Yes. And furthermore, according to this picture, the trajectory into the putamen also parallels the LSEs and LTVs. In the putamen, minimize the risking of vascular injury. And we can see that the SS penetrates the anterior perforated substance in here to supply the basal ganglia, cortex nucleus, and the capsule. And based on their point of origin, the LSAs are categorized into lateral, intermediate, and medial groups. The lateral group originates from the M1 segment. The intermediate group is located between the lateral and the medial groups. The medial group arises from the distal bifurcation of the MCA. The LSA supplies the putamen, globus pallidus, with the lateral and intermediate groups also supplying the entire superior part of internal capsule and the head and the body of the cortex nucleus. The medial group supplies the superior part of the anterior limb of internal capsule and the anterior superior part of head of cortex nucleus. and its corresponding schematic illustration. Okay, in this picture, we can see that the SAs do not arise directly from the MCA. It's not direct. Instead, they travel parallel to the MCA, moving toward its bifurcation before turning upwards into the basal ganglia. And Professor Roten described this pathway as an S-shape courses. And in our study, we can see the SA follows a reverse L shape, providing a refined understanding of these anatomic structures. From a hemodynamic risk perspective, this configuration makes it more difficult from small emboli to block the LSAs. And this distinctive shape also creates a condition where aneurysm were more likely to form the origin of the LSAs. Additionally, multiple branches of the LSAs arise from the MCA without direct communication between them, which ensures efficient and robust blood supply to basal ganglia. This branching system optimizes the perfusion of its critical brain region, even when of several branches become compromised. And this DSA study also confirms this, the shape of reverse L. Yes, you see the larger view here. Okay, although imaging and navigation technologies have advanced rapidly in recent years, and neurosurgery remains fundamentally an anatomical-based discipline. Studying anatomy not only helps us understand the structural organization of the brain, but also enables more precise and effective application during surgery. For example, here, based on detailed anatomy studies of white matter fiber tract and the vascular structure of the cerebral, we have proposed the concept of sublobectomy for GBM, and the related clinical study has been accepted for publication in the GNS. This approach is an anatomy-guided resection strategy for GBM that relies on identifiable anatomical landmarks and allows more thorough tumor removal. The detailed surgical technique will not be elaborated here. Instead, we will present several illustrative examples. And we can see this is the image of a large GBM located in the right frontal lobe. And we can see the anatomical landmarks. So in the sublobectomy, we can see the anterior boundary will be the frontal pole, the posterior boundary, the superficial is premotor area, deep is corpus callosum, and the medial boundary, we can see the superficial is cerebral forks, and the deep is corpus callosum system. The lateral surface is superficial, we can see lateral fissure, posterior portion of inferior frontal gyrus, and deep is superior living sulcus and the anterior living sulcus of the insula. Of course, the basal surface, we can see the anterior skull base. So we can see this picture. The whole tumor is removed, but also the sublobectomy. The present gyrus is here, just a posterior to tumor we have preserved. We can see it's both the frontal horn and the body, the genuine of the corpus callosum. And the basal is skull base. You can see that CN1 is here, and this laterally is olfactory triangle, and you can see this basal ganglia. The tumor has embedded here. We also removed. It's the anterior limb. It's putamen, and just said it's the capsule, and this is the insula, long insular gyrus, and the temporal lobe is here, and the medially is the forks, of course. And the patient's tolerance of surgery is where we can see the post-surgery pictures here. Yes, the patient's tolerance of surgery. Yeah. Okay. And this is the left frontal lobe. We can see we preserve the functional area is preserved here. And this is the temporal lobe. Okay, this is the parietal lobe, subparietal lobe lobectomy. And this is look through the lobectomy. In the breast Wisconsin test analysis, sublobectomy was associated with clearly longer survival than CE resection alone. Median overall survival was 25.6 versus 18.1 months, and the median progression-free survival was 70% versus 12 months. To address the baseline imbalances between the two groups, we introduced the RPTW balancing. The survival association remains robust. Median OS was 26.2 versus 18.7 months, and the median PFS was 70.4 versus 20.7 months. So even after adjustment. Okay. Thank you. That's all. I will speak again. The anatomical knowledge provides neurosurgeons with a more comprehensive perspective for understanding the entire surgery.
Great talk, Chen Li. Thank you. And it's very nice how you put the
I
surgical
hope next
picture.
time I may have honor to introduce the structure of the base of the brain. Thank you, Ribas.
It's nice. Very nice pictures and nice presentation also, of course. And it's how you put all those fibers, and in the end, you put the frontal lobectomy. This is a very common procedure, frequent procedure, sure, for gliomas, and we should all know how to do it. And it, with all this anatomical knowledge, I'm sure you can do this with more efficiency and, of course, with more safety for the patients. And I like to see the picture. Very clean lobectomy. The lateral ventricle opened, and
Yeah.
on the right side it was a little bit easier.
Our side, yes, the right side. Yes.
But very nice.
Thank
So if any of the panelists has some questions, or we can leave the discussion for after. We just to talk about with everybody that's listening to us, we had a little bit of confusion about the time. GMT and London time, they are not in agreement now because it's summertime in London. So it's but I think we are gonna have for sure recording of these sessions, and we are gonna post it later under the World Federation website, and I'm sure everybody can go for these recordings later. I'm going to give the next talk. So the idea of these seminars is to understand the anatomy behind most of our neurosurgical procedures, of course, the most common ones. And the idea is to come from the superficial lesions toward the deep lesions. And this webinar today is about the cortical lesions or the lateral aspect of the brain. So Dr. Chen Li talked about the fibers, fibers that are overlying the lateral surface of the brain. Now I'm going to talk about the cortical surface of the brain, and later Pablo from Alicante is going to talk about how to brain map these regions, cortical and subcortical structures, and to do a good job at this region. My name is Eduardo Ribas. I'm a neurosurgeon from São Paulo, Brazil. I did my training here at the University of São Paulo. I currently work at the Albert Einstein Hospital at the city of São Paulo also. But most of my anatomical knowledge I gained, I would say, from my father. Dr. Guilherme Ribas is a neurosurgeon and neuroanatomist from Brazil, and also from Professor Albert Rotten from the University of Florida, and I'm very proud to have been his fellow. So now I'm just trying to share my screen, and I'm gonna bring in my sharing. I think it's working. If Petra is the one,
we can see it. We can see it. Wonderful.
You can see. Thank you. So I'm going to talk about the lateral surface of the brain, and some of the key points later, how we can understand what's the lateral surface that is underlying the bone that is overlying. So why does the brain has this very particular shape with convolution? Why it's convoluted into sulci and gyri? The answer begins in the embryology. During the formation of the brain, the embryology of the brain, a lot of processes happen that will fold the brain into itself, creating this appearance of a crumbled piece of paper. So if you take a paper, all the surface in the paper, if you crumble it in a ball, it will have its convolutions, of course, but the surface is hidden inside its convolution. It's said that 2/3 of the surface of the brain is not actually on the surface of the brain, but hidden inside its convolutions, its sulci and gyri. But of course, the gyri continue themselves together, is a true continuum. There is not a natural cleft separating one lobe from the other. So the idea of the lobes, it's idea of having the names of the bones that are directly overlying each piece of brain, and just giving the name of the bones to the name of the lobes, of the cerebral lobes. In the beginning of this idea, the anatomists were using the division of the bones as the division of the lobes. So at this first time of neuroanatomy, we were using the sutures. So what is the suture that is dividing the frontal lobe from the, what's the suture that is dividing the frontal bone anteriorly from the parietal bone posteriorly? Of course, is the coronal suture. If we go more deep, we can see here the epithelium, this H-shaped suture between the coronal suture anteriorly and the squamous suture posteriorly. Later on, as neuroanatomists began to understand more about the surface of the brain, these bony landmarks were replaced by cerebral landmarks. So nowadays we divide the brain into its lobes by using cerebral landmarks. The first main landmarks that we need to understand is the Sylvian fissure. The Sylvian fissure, also called the lateral surface, the lateral sulcus of the brain, is of course on the lateral aspect of the brain, and it's dividing frontal and parietal lobe superiorly from temporal lobe inferiorly. Then we have the central sulcus. It's a very distinct sulcus of the brain because it's not exactly vertical. It's in one oblique sulcus. It's also more continuous. It's not frequently interrupted. It's almost always continuous, and it's almost always isolated because the pre and post-central gyri just connect themselves inferiorly and superiorly. So the sulci anteriorly and posteriorly, they do not reach the central sulcus, given its very isolated appearance. So it's very easy to locate the central sulcus by these three hints. So it's oblique, it's continuous, and it's isolated from the others. And then we will trace an imaginary line beginning in the preoccipital notch, what is a very good name here because it's preoccipital. There is a small bump here. At the top of this bump is the preoccipital notch. And at the top of this bump, we will begin to trace this imaginary line that will go more medially towards the parietal occipital fissure. Now, the parietal occipital fissure is a deep cleft just seen on the medial aspect of the brain, but this is where this imaginary line is going to. And with this imaginary line connecting its midpoint to the end of the Sylvian fissure, we can now see the boundaries of all four cerebral lobes that are on the lateral surface of the brain. So we have the frontal lobe, parietal lobe, occipital lobe, and then temporal lobe. Deep to the Sylvian fissure, we have the fifth cerebral lobe, that's the insula, not really on the lateral aspect of the brain because it's hidden inside the Sylvian fissure. Paul Broca, more known by discovering the speech area of Broca, also detailed the idea of the sixth cerebral lobe is the limbic system, because he realized that some structures are going around the thalamus. He saw the thalamus as the morphological center of the brain, the most important part of the diencephalon, right? And he saw that some structures are making some Cs around the thalamus. So we see more two big Cs. We have the outer C, the cortical C, made by the cingulate gyrus and the para-hippocampal gyrus. This is the outer cortical C of the limbic system. And an inner C, because inside the para-hippocampal gyrus, we'll have the amygdala and the hippocampus. And the hippocampus continues itself with the fornix and finished in the mammillary body. So it's the inner C, the subcortical C. So we have 6 cerebral lobes. Another way of understanding the brain is understanding its surfaces. We have 3 surfaces of the brain. The superolateral surface is the one that we are going to talk today, is this one on the top. But of course, we have these 2 other surfaces. We have one medial surface and one inferior or basal surface. At the lateral aspect of the brain, we have a lot of sulci and gyri, but during surgery, they are really difficult to be seen because we have all these vascular structures overlying the sulci, and we have also the arachnoid. So we have to know this from anatomy. So that's why we need to go to neuroanatomy labs, learn the brain without all these structures that are overlying the sulci, so we can apply this knowledge later into surgery. The main structure that we need to focus on is the Sylvian fissure. This is just the lateral extension of the Sylvian fissure, but we need also to understand the Sylvian fissure as continuing ventrally, medially towards the polygon of Willis. This is the main neurosurgical route from the lateral to the basal sisters. This is a magnified view, as we can see where the MCA would go through from the lateral to the medial perspective. And this is the main route for the neurosurgeon to reach here and to treat, for example, aneurysms. And this is the stem of the Sylvian fissure. M1 would be from the beginning of the bifurcation, of course, towards the limb insula. The limb insula is this structure here where the M1 is bending and then becoming M2 directly over the insular surface. And then M3 would be superior and inferior, overlying the opercula, superior and inferior, and then M4 already on the lateral surface. This book has almost 100 years old, and it talks about the lack of consistency. If we see a set of brains, no brain will be identical from the other, not also from the left side, from the right side. So we have to take, of course, this idea of the lack of consistency. But there is a blueprint. There is a way to understand the lateral surface of the brain. So I'm going to try to summarize how we can explain for students this. So the brain has 3 poles. We have one frontal pole, one temporal pole, and one occipital pole. At each pole, 3 different gyri will converge. We have 3 frontal gyri, 3 occipital gyri, and 3 temporal gyri, and their names are very easy because they're just superior, middle, and inferior ones. Also, we have one ellipse in the middle of the lateral surface. This is the pre and the post central gyri that connect themselves just superiorly and inferiorly. And that's why the central circus is so continuous and uninterrupted, because this ellipse that is formed anterior and posterior by the pre and post central gyri just connect themselves superior and inferior. These points of connection have also been named by Broca as the inferior Hollandic point and superior Hollandic point, because Luigi Hollando is the one that first described the Sylvian fissure. So inferior Hollandic point and superior Hollandic point, as we're going to talk about them later. Some people have more trouble understanding the parietal lobe. So the parietal lobe is made by 2 lobules. The superior parietal lobule is a quadrangular piece of bone, medial or superior to the interparietal sulcus. The inferior parietal lobule itself is made by 2 arched gyri. The one that is more anterior is arching itself over the posterior margin of the Sylvian fissure. So that's why it's called the supramarginal gyrus, because it's overlying the posterior margin of the Sylvian fissure. So supramarginal gyrus, and then angular gyrus posterior to the supramarginal gyrus. The operculum is at the lateral aspect of the brain. We have a superior operculum and then an inferior operculum, and it's just overlying the insular cortex. This is important to understand, and Chen Li talked about the perisylvian network that is really inside the opercula, and it's important for language functions on the dominant side. Now we can see some of the lobes here. As I said, 3 gyri will convert themselves into the lobes, into the frontal pole, and the middle frontal gyrus is usually very big. So some people, we can talk about, is this the primary sulcus? Is this the superior frontal sulcus? I would say the superior frontal sulcus is superiorly, and the inferior frontal sulcus is here inferiorly, very interrupted, making the middle frontal gyrus very big. I would say this is all middle frontal gyrus. As you can see, the middle frontal gyrus connects itself with the precentral gyrus. And this central sulcus is interrupted by disconnections of the frontal gyri. Here is the connection of the middle frontal gyrus, but the superior frontal gyrus also connects itself to the precentral gyrus, and the inferior frontal gyrus also connects itself to the precentral gyrus. This connection, this inferior connection of the inferior frontal gyrus with the precentral gyrus has other names. For example, this is also called the pars opercularis. Opercularis because it's directly overlying the insula already. Dr. Guilherme, for example, always remember us that this piece of brain always resembles a new shaped convolution here. So the pars opercularis is a very is a very frequent and consistent shape for us to see. Another specimen, same idea. So we have the frontal, the superior frontal gyrus here connecting itself with the precentral gyrus, middle frontal gyrus connecting itself with the precentral gyrus, and inferior frontal gyrus connecting itself with the precentral gyrus. This connection will interrupt the precentral sulcus. But the central sulcus directly posteriorly is continuous. So it's oblique, continuous, and isolated. Of course, anterior and posterior to it, we'll have the pre- and postcentral gyri. Another specimen, again, the same idea, superior, middle, and inferior frontal gyri, all 3 connecting themselves with the precentral gyri. By this connection, the precentral sulcus is interrupted. Just to see the parietal lobe begins itself with the postcentral gyrus, and then from the postcentral gyrus, connections will arise and connect with the parietal lobules also. These connections will also interrupt the postcentral sulcus. So the pre- and postcentral sulcus are interrupted by connections, but not the central sulcus. I'm just being firm on this statement because this is very easy for us to recognize where the central sulcus is. So you can see here is the connection of the postcentral gyrus with the superior parietal lobule. And here is the connection of the postcentral gyrus with the supramarginal gyrus. Between superior parietal lobule and inferior parietal lobule, we have one sulcus that is positioned from anterior to posterior. This is, of course, the interparietal sulcus. So you need to look for it. What is the only sulcus in this region here that is coming from anterior to posterior? This has to be the interparietal sulcus. Medial to it, we have the superior parietal lobule. Lateral to it, we have the inferior parietal lobule. And as I said, you just recognize the inferior aspect of the Sylvian fissure. The sulcus that is overlying this posterior aspect will be the supramarginal gyrus. This has to be the supramarginal gyrus. And directly posterior to it, we'll have the angular gyrus. Occipital lobe, we will look for 3 gyri merging into the occipital lobe, into the occipital pole. As you see, the inferior occipital gyrus is a true continuation of the inferior temporal gyrus. It's the same piece of brain that continues itself, but changes its name as it passes through the preoccipital notch. Anterior, it's called temporal. Posterior, it's called occipital. The same brain seen from posteriorly. So here we have the occipital pole. So we have the inferior occipital gyrus coming here and the superior occipital gyrus coming here. What is the superior occipital gyrus? The superior occipital gyrus is in fact the continuation of the superior parietal lobule. As the superior parietal lobule continues itself posteriorly, it has to change its name as it becomes occipital, and then it's called the superior occipital gyrus. This changing of names, it's at the parietal occipital fissure here, the very big cleft on the middle aspect of the brain. And the middle occipital gyrus, it is a little bit more inconsistent. So at this specimen here, we will see this very horizontalized, but in the next specimen, we will see very verticalized. So the middle occipital gyrus can change itself more often, but the superior one is more vertical and the inferior one is more horizontal. Of course, remember that the cuneus is part of the occipital lobe, and directly under the cuneus, we have the lingual gyrus, also called the medial occipital-temporal gyrus, but this is, of course, at the middle aspect of the brain. Temporal lobes, perhaps the most easy one, we'll look for 3 gyri merging itself anteriorly into the pole. Between them, we have two sulci. The superior temporal sulcus is usually very continuous and deep, while on the other hand, we have the inferior temporal sulcus. It's more frequently interrupted and more shallow. So you see this at this specimen, as at the next specimen, you see the same configuration. The superior temporal sulcus, more deep and more continuous, totally different from the inferior temporal sulcus, which is more interrupted and more shallow. This anatomy has been reviewed by a lot of authors, and it's very important from transsulcal approaches, as it has been described by Professor Yasha Gill some decades ago, how to use the brain sulci as true neurosurgical corridors to get inside the brain. Of course, the split of the Sylvian fissure, one of the main steps of some of our neurosurgical procedures. As the brain unfolds itself, crumbled like the piece of paper, its surface becomes inside the cerebral sulci, and it brings itself with the arachnoid and the vessels that are overlying. So you can see the arachnoid space as continuing itself inside the sulci. Also, if we use the sulci as the route to get inside the brain, we will damage less fibers than if we use the apex of the gyrus, because the projection fibers will arise more often from the gyrus, but not from the sulcus, not from the valley itself. So if you use the sulcus, you will harm less projection fibers, at least from an anatomical perspective. But also you can use the sulci knowledge to use the transcortical approaches, as you can deal with the lesions, understanding its compartment, and you can use sulcal to sulcal resection or understanding the position of a lesion based on its relation to the sulcus. So how to understand where the main sulci are during surgery, and of course during surgery they're very hard to be recognized. So we'll use our anatomical knowledge and our technology, of course, and we can base ourselves on some key points that have been studied by a lot of neuroanatomists in the past, and Dr. Guilherme chiefed our group of study, who studied some of these old key points, but also came up with some new key points. So this is an old knowledge that had been reviewed. Other people will use some other techniques, for example, the Taylor-Houghton lines, as Professor Rotten puts in his book, and is also at the Humans book. But another approach is to use the key points. So which are the key points? The key points are some points of meeting points of some major sulci, and at this meeting we will have a very easy recognition of them, because as they meet, they form a very cisternal point, very easily recognized during surgery. So this is our group of study, chiefed by Dr. Guilherme. he studied 32 cerebral hemisphere and came up with some key points. So this is the meeting point of two main sulci, and as they meet, they form a key point. And the key point has this external appearance. It's larger, it's more easily recognized. And after recognizing the main meeting points, the main key points, he related where they are in relation to the bone, but also understood its relation to the deep aspects of the brain also. And he came up with a framework, a set of some key points that can be used by the neurosurgeon. So I'm going to talk about just some of the key points, and you can look for our articles later. So where is the Sylvian fissure? You need to understand two main points. One is the anterior Sylvian point, described many years ago by Floriep. This is where the Sylvian stem becomes the lateral extension of the Sylvian fissure. This is directly inferior to the pars triangularis. And as the pars triangularis is usually more retracted from the Sylvian fissure, this is really a point here. This is really a cisternal appearance. So as you see some other specimens here, how the pars triangularis is more retracted, forming a point that is really easy to be recognized. And if you recognize where the anterior Sylvian point is, you can later recognize all the rest of the operculum by its U's and C's forming posteriorly. So you take one point as your landmark and understand the rest of the Sylvian surface relating to this key point. Also, the anterior Sylvian point is where the Sylvian opening, the Sylvian fissure opening will begin. If you open at this point, this is usually just a little bit anteriorly from the Lyman insula. This is where M1 becomes M2. So this is a very easy place for you to begin the opening of the Sylvian fissure. Where is this point at the bone? This is at the most anterior and superior part of the squamous suture. So as you elevate the mucocutaneous flap, you will see the bone and you will see the sutures. So where underlying the sutures is the anterior Sylvian point? The anterior Sylvian point is at this part here, is where the superior aspect and the anterior aspect of the squamous suture meet themselves. It's here. Here is the anterior Sylvian point. Another point is the inferior Hollandic point. This is where the central sulcus meet or would meet the Sylvian fissure. Where is this point? This is at the topmost of the squamous suture. So just by facing the squamous fissure, the squamous suture, you can understand where the Sylvian fissure is under it. Another idea is to understand where the central lobe is. The central lobe is, of course, has on its middle the central sulcus, and it's defined anterior and posterior by the pre and post central sulcus. The pre and post central sulcus is very important to be understood where they are, because the surgeon who is working on the frontal lobe does not want to go posterior from the pre-central sulcus because he doesn't want to get inside the motor area, right? And whoever is dealing with the parietal lesions does not want to go anterior into the somatosensory region. So he needs to understand where the post-central sulcus is. Where are those sulci? So first understand the bregma is about 12 to 14 centimeters behind the nasum. The nasum is very easily to be palpated at the top of the nose, and then 12 to 14 centimeters, you see the bregma, and lateral to the bregma, you can palpate the coronal suture as well. Where the coronal suture meets the superior temporal line, a craniometric point called the stephanium. So it's where the coronal suture meets the superior temporal line. Very easily to see as you elevate the bone, the skin flap. You just underline the skin, you see the coronal suture, and then you see the temporal muscle. Where they meet is the stephanium. And the stephanium marks the point that is directly overlying where the inferior frontal sulcus will meet the precentral sulcus. So what information this point gives to you? That you don't want to go posterior to this point. If you go posterior to this point, you will get inside the precentral gyrus. This is the motor region, so you don't want to go posterior to this point. The other point is where the superior frontal sulcus meets the precentral sulcus. This is usually 3 centimeters away from the midline and 2 centimeters behind the coronal suture. So if you see the coronal suture, you just by pointing these 2 points, you can understand where is the precentral sulcus, informing you that you do not want to go posterior to it. The central sulcus is between the inferior Hollandic point and the superior Hollandic point. The inferior Hollandic point is, as I said, at the topmost of the squamous suture. And the superior Hollandic point is usually 5 centimeters posterior to the bregma. Just with these 2 points, we can understand where this lesion is. So this lesion is at the middle frontal gyrus, is at the posterior part of the middle frontal gyrus, so directly anterior to the precentral gyrus. And so where is it? So if we take the Stephanion here, the Stephanion is where the coronal suture meets the superior temporal line, so the muscle itself. Here is where the inferior frontal sulcus meets the precentral sulcus. And the next point is 3 centimeters away and some centimeters behind, usually 2 centimeters behind. This is the precentral sulcus. Lesion has to be here. The posterior aspect of the middle frontal gyrus is here and the lesion is there, so the lesion has to be here. Of course, we will use neuronavigation as well. We will not discard any technology that we have. We use all the knowledge and the technology that is available for us. But if we see the coronal suture, we know that the lesion will be here because it's directly posterior to this region here. We like to make big craniotomies, big openings. You can see a little bit of bleeding here, hemosiderin here, and you can resect the lesion and make a good job just using craniometric points just to understand what it is. The same place of work here, so the posterior aspect of the middle frontal gyrus, we will of course use technology and radiology. So we know this is at the posterior aspect of the middle frontal gyrus. This will look like a rhomboid shape. The same key points we're going to use. We're going to look for this shape here. So the same shape that we saw in the MRI, we will look for this shape here, as low-grade gliomas might resemble the normal brain itself. And we like to use brain mapping, as Dr. Paulo is going to talk later. The last sulcus that I'm going to talk about is the postcentral sulcus, just by understanding where this point is. This point is where the postcentral sulcus touches meets the intraparietal sulcus. So this point here will inform the surgeon that he does not want to go anterior to this point. Otherwise, he will get inside the postcentral gyrus. Where is this point? This point is 6 centimeters anterior to the lambda and 5 centimeters lateral to the midline. Another point is the eurum. The eurum is the parietal tuberosity, is where the parietal bone is more far away from midline. Eurum means itself, it means more far away. And where is the eurum? The eurum is overlying the anterior aspect of the supramarginal gyrus. So this region here, directly at the supramarginal gyrus, will be directly underneath the eurum. So if we understand where the eurum is, make a brief craniotomy there, we will see the brain. And of course, we will see that the low-grade glioma is here because the brain is a little bit more pale. The vascularization is a little bit more scarce at this region here. So the low-grade glioma is here. And we like to do sulcal-to-sulcal resection. This is Dr. Guilherme working and resecting this glioma here and making a good job. So he resected this region. This region was the supramarginal gyrus. And this is more in the middle aspect of the brain, but just understand that the lambda and the pistocranium is the most posterior point of the skull. They will be directly at the posterior aspect of the parietal occipital fissure and the calcaneal fissure. And of course, between these 2 points, we have the cuneus. So where the cuneus is between the lambda and the pistocranium. This is directly the limits of the cuneus, of course. So thank you for this opportunity to teach. And if we have some questions, or I can invite our next speaker.
Thank you, Eduardo. It was a great talk. I've heard similar talks many times, but never stop enjoying listening to it and always learn something.
Thank
May I ask, when you resect glioma, let's say there's a glioma that looks from 8 sulcus to 8 sulcus. Do you go into the sulcus or how do you resect the glioma?
I use the sulcus as a guide, but nowadays I'm going, I would say, directly lateral to the sulcus. So I get inside the brain. Since I'm gonna resect this region, is already taken by the tumor. But I'm going to use the sulcus as the boundary. So as the sulcus will have vascular structures inside it, I don't go inside the sulcus. I get inside the brain and then go like a subcortical resection against the sulcus. And I see on the MRI also how deep to the sulcus the lesion reaches. So just yesterday I resected the lesion that I knew it was like 1 centimeter deep to most of the sulcus. So I use the sulcus as the lateral to understand the compartment, but I also use the depth of the sulcus to inform me how more deep I should go. When the sulcus ended, I understood that I needed to go still 1 centimeter more deep. So I just use this as a guide, but not really going transsulcal, but parasulcus or directly inside the brain. How do you do
This
it?
was I think this was a great answer, and again, anatomy is something that we can learn a great deal from. Obviously, you talked about the U fibers and projection fibers and so on, and we know that if we go through the sulcus, we avoid lots of the projection fibers. Obviously, surgical damage is not limited to the direct brain damage, but it can result also from vascular injury, from ischemic injury. And we all know that sulci contain vessels, and small sulci will contain maybe small vessels, and bigger cisterns will contain bigger vessels. And also different functional consequences in different areas of the brain. So I think once one is aware of all of that, then one makes specific choices in specific situations. Also, pathology differs, right? So some gliomas, particularly low-grade gliomas, they generally respect PL surfaces quite nicely. However, there will be some higher grade gliomas, particularly some GBMs with various sarcomatous differentiation that will go into the sulcus, embed the vessel, go through the other PL surface, and go to the other brain. So as we gather more experience, we know what factors are in play and what are the consequences of taking our choices. Well, I can see that we have the wonderful Professor Guillermo Ribas with us today, who has taught more people around the world about anatomy of the brain than anybody else I know. I'm sure you have some comments to make, Guillermo.
Well, first of all, it's a big pleasure to be here joining you all. Seeing you, Tom, after this long road we had already with some decades, and seeing Eduardo talking about the Sulcal Key Points. I would like just to emphasize something that he said, The Sulcal key points we studied are indeed an evolution of the craniometric points that were described by Broca in the second half of the 19th century. So what we did, we adapted these craniometric points to this new microanatomy knowledge and described a few other points that might be of interest for the practice of microneurosurgery. The main article, as you saw, was published 10 years ago. And I would say that this was my main article because this is something new that I was really proposing. And it was based on the fact that, as you all know, particularly we neurosurgeons and also neuroradiologists and neurologists, we need to develop a mental map, a three-dimensional mental map of the brain and skull, which you have to continuously refine along our practice. Really have to have this architecture of the brain of the skull inside our own heads. And the Sulcal key points Eduardo just talked about can and should be used as landmarks. They should be used as real anchors for this knowledge, for this understanding of the brain architecture, just as the backbone of it. For example, I work in a general hospital here, and I have subdurals to be done almost every week. And the more you do, the more you learn, the more you know. And I try to look at the subdurals anatomically as everything. You always have to think anatomically. I see what gyri the subdural is covering. What gyri in sulci are the limits of the subdural. And then I use the craniometric points to see where I'm going to put my burr. For example, the aurium, that it's the most prominent point of the parietal tuberosity or parietal bossa, is where the brain is more far away from the surface. This is a good point to do a burr for a subdural, but you have to make sure the subdural is reaching underneath this point. So for this, you have to understand that this point is over the supramarginal gyrus, and you begin to see anatomically that the subdural is so you have to use this for everything and think about this all the time, and this will enhance very much your knowledge of this brain architecture. So
I'm very glad you mentioned
in the seminars are talking about this here.
I'm very glad you mentioned subdural hematoma as well, because this is indeed a condition that when I see most misplaced burr holes simply by people, usually done by relatively beginners, and the sort of either sort of deliberate or just enforced ignorance of anatomy manifests itself most obviously. Sorry to interrupt, but I thought I must mention it. That anatomy is absolutely essential for anything we do, even supposedly the most simple stuff.
So I'm seeing here at the Q&A there we have we have just one question from the audience. Of course, everybody should feel free to write to us, so please do. It's written, the transsulcal approach, should it never be used or use it? Someone was asking about this. So as I said, I do not use the transsulcal approach when I'm dealing to gliomas, because the glioma will take this region, and so I will just use the sulcals to guide myself as the limit of this compartment, because usually the low-grade glioma will enlarge by structure. It will enlarge a region, and if you go from sulcal to sulcal resection, it's a mental guide that you can use. So I used the sulcals as the guide, but in other procedures, I might use transsulcal approaches. For example, if I want to get inside the ventricle, so imagine there is a ventricular lesion. So the brain convolutions themselves, they are not taken by any disease. So I want to preserve them. So then I will use the transsulcal approach to get inside the ventricle. So this is just to answer one of the questions.
I can see we have Professor González-López with us as well. I'm sure you have some comments to make. I'm sure you have picked up something we said wrongly.
Come on, Tom. Absolutely. It was excellent. I'm sorry I was delayed. And I must say that I feel very, very honored to be among us, among you. And Professor Ribas, indeed, probably he does not remember, but he was one of my mentors in 2009 when I was in Sao Paulo. I spent 3 months there. So I was a second-year resident at that time. So you can imagine how I feel today. It was great. And regarding the transsulcal, transcortical, I fully agree with Eduardo. Completely agree on that. Indeed, for surface gliomas, I try to find them easily. Ultrasound is very useful for that nowadays if you don't see this bulging convolution. And I try to imagine where are the anatomical sulcal limits for the glioma, and then I go directly into the affected gyrus and I expand the resection towards the sulcus. So I try to, with that, to doing the subpial dissection, resection to protect the vessels inside which are in passage, and we don't want to damage them. So I fully agree with that comment, I'd say.
The other, thank you, Pablo, very much. The other thing that I hope is going to come through during this meeting and through the other webinars that we may run as anatomy is that it's always good to have several different ways of verifying what's going on. Yeah, trust but check. What we must not do blindly follow something that we can't verify. And there are various methods of verifying things. Craniometric points are the one of them. Also, simple comparison of what you see on the preoperative scan and what you see intraoperatively. For example, veins are extremely useful. You can see them both on T2 scans or T1 with contrast, depending exactly on the phase and so on. So there are lots of different ways you can make sure you are where you are. So
even mapping cortical stimulation sometimes can help you to identify yourself where you, and if you should go anterior or posterior, more lateral, more medial, that could be also helpful.
Absolutely. I mean, certain areas of the brain are, we often argue about the word eloquent, non-eloquent, but essentially what we want to say by eloquent in this context is if something happens right here, even 1 millimeter square, there will be functional consequence, and there are some areas like that, including primary motor cortex. So it is absolutely essential to know exactly where you are, perhaps more so in some places than some other places. And in these other places, not only direct brain damage matters, but also a relatively minor vascular injury will have much greater impact than perhaps in some other areas of the brain. So the more we know, the more we potentially worry about, the more we take into consideration. And hopefully, the better off will our patients be. Eduardo is the chair today, not only a speaker.
So, yeah, I should present our next speaker. Our next speaker is our friend, Pablo González-López, our friend from Alicante, Spain, but also an international friend as we meet all around the meetings all around the world. And last year we were in Cambridge, of course, with Thomas Santarius. And it was great to see you fiber dissecting and talking about the brain mapping. So it's a pleasure to have you today with us, talking about his true specialty, but how to brain map with all this neuroanatomical knowledge. I'm sure he can go further because he can combine these two knowledges, the brain mapping, the functional knowledge of the brain, but also the structural knowledge of the brain, the neuroanatomy itself. And I'm sure this is why he can make so good surgeries, Pablo. So it's a pleasure to have you here. If you can share your screen and.
So please just let me know if you can see. And
yes, it's beautiful.
Let's go again. Thanks a lot for the invitation. That meant a lot. to me to spend this time with you, and I'm going to try to share with you exactly what you have described, Eduardo, how we can implement our anatomical knowledge into the OR for a perfect surgical planning, which will guide us to a much better surgical outcome. This is the key of today's lectures, I guess. This is the anatomy. This is the tree in which we have to deal with. So here we see white and black and gray colors, but this is the true anatomy, and these are all the different structures that we should perfectly understand in order to not only to resect the tumor, but most importantly, to plan how to do that. The external mantle has already been discussed. We have the cortex, the surface, and in the central core, we have white matter, which is made of association, commisural projection fibers, and also some gray matter at the level of the basal ganglia, thalamus, and also the dentate gyrus of the hippocampus. So this is the lab I was telling you about. This is the Sao Paulo lab in 2009. And this is the kind of tools I was using. I'm joking. But it was a fantastic time in which I really learned a lot. This was my first experience with white matter dissection and the subcogitral anatomy. And I always remember this time there in which I really learned how to plan a surgery, how to identify where our gliomas are located and how we can deal with them. This is one of the white matter dissections. This is 3D scanned. We did this dissection together. Indeed, I saw Igor around. We did this dissection together in Manipal a few years back. So after trying to keep all the fibers of the lateral aspect in the same hemisphere, it's a challenging topic. But we tried to show the dorsal ventral streams association and also projection on some commissural fibers. So here you can see the central sulcus with the corticospinal tract. All these fibers are projection going down. Then we have the SLF 2 and 3, which, as you can see, there is not a clear definition on differentiation in between them. It's the same mantle. And even we have the arcuate, which are those more ventral fibers which are turning around and wrapping around in order to reach the temporal lobe. Then we can see the external extreme capsules and internal capsule. In between them, we have the basal ganglia, IFOV, which has been cut right there, and the anterior commissure, a commissural fiber tract just underlying the uncinate and the optic radiation. So we can see all these fibers from the lateral aspect right there. This is the lab I went after that, where I did my fellowship, and it is my eternal gratitude to Professor Ture and Professor Yasserhill, from whom I really learned a lot in the lab, working hard for 1 year on these white matter dissection fibers. So Tom was discussing what is eloquent. I don't know the answer, but I would say it's all those parts of the brain which made us human beings. So it's not only cortical regions, but also, very importantly, they are neural connections. And these neural connections are not only important to be identified, but also to understand how these gliomas are bonded and sometimes how they are growing in between the different sulci and gyri. It's very clear that the extent of resection is fundamental for glioma surgery, at least at this moment. And the key is to try to diminish morbidity and enlarging our resection. So maximize our resection, minimize morbidity. And for that, we need not only all our OR tools. Technology is very important, but mainly we have to understand the anatomy, which is for me the key of the perioperative planning, which indeed is the key for a successful surgery. And we have fMRI, DTI, anatomical sequences, navigation, ultrasound, everything available, but nothing compared to neuroanatomical knowledge. This is my really take-home message today. So surgical planning, for that I'm going to share with you some of my cases and try to share with you how I think about them. So this is something I got from Professor Ture. So choice of the approach-based anatomy for a glioma, you have to go through anatomical corridors, perform anatraumatic manipulation, and respect the surrounding structures. For that, you have to know anatomy, you have to select properly the approach and positioning of the patient, and to respect the surrounding structures. Something very useful is brain mapping, which is what we are going to be talking about. Enter the sick functional unit once the sulcogyral anatomy is very clear, and I try, as I said before, to stay within the tumor, expanding the resection towards its anatomical limits. So let's go to the first case, supplementary motor area glioma. As you can see right there, first important thing, identifying where is it located, which is a functional term, supplementary motor area. But talking about anatomy, we have the interhemispheric fissure, cingulate sulcus, and superior frontal sulcus. This is the posterior third of the superior frontal gyrus. So if we identify intraoperatively all these structures, we will have a very good result. But we can also have functional MRI where we are reinforcing our points. As you can see, precentral gyrus, so motor strip is just posterior to the tumor, and very, very in close contact, the leg location in the motor strip. So here we have pre and post-central gyri, and then we start thinking all the way during the preparative planning about what kind of structures we will be finding. So we try to do this 3D reconstruction, and then we try to draw what is this glioma located. So we try to place the patient or the head in anatomical location. So here we have this posterior third of the superior frontal gyrus. So this is frontal sulcus, this precentral sulcus, interhemispheric fissure, the cingulate sulcus, and last but not least, very, very important and careful to identify this pied de passage in between the superior frontal gyrus and the precentral gyrus, where we will probably find some functional response. Something important is how deep we want to go, and in this case, we need to understand that the corticospinal tract is just posterior and deep to this glioma, so brain mapping will also be very important at this aspect of the subcortical level. So as you can see, these are the parts that I will be dealing with at the end of the surgery, just in case we damage them, to try to diminish the damage of these structures, which the goal is minimize morbidity. So this is the view we have, and as Tom has said, it's not only about sulcogyral anatomy, but also about veins. So implementing the venography can give us a nice understanding of where the tumor is located. So this is the pied de passage, this is the precentral gyrus, and this is the posterior third of the superior frontal gyrus. This is a very, very important area because maybe we have some glioma there, but we could find also some response on the leg. So opening the dura and trying to identify all these structures, N20 wave inversion. This will give us the relative location of the precentral gyrus, and then we orient our MEP grid in the direction of the precentral gyrus, identify the superior frontal sulcus and the interhemispheric fissure, and as I said before, from the center of the tumor, we expand the resection towards the anterior, lateral, medial, and deep limits. As you can see, I'm protecting this area with a cottonoid because this is the area I want to deal with at the end of the surgery. So going now anterior, this is the subpilar resection. I'm looking for the cingulate sulcus in the depth, and you can see it here with the callosomarginal branches right there. And this is the sound of this classic subpilar resection. So moving anteriorly, cingulate gyrus, depth of the cingulate sulcus, and this is our limit. So we are quite anterior, so we are not worried in this point about the corticospinal tract, but in case we get close to them, we have the MEPs. So now we move slightly and progressively posteriorly and lateral, and we are reaching that area in which we might have some response, and remove this part of the tumor, getting close to the precentral gyrus. And now moving a bit posteriorly in the depth of the cingulate sulcus. So as you can see, we are going from anterior to posterior to the areas in which we expect to find the corticospinal tract. This is the precentral sulcus, the depth of the precentral sulcus right there, callosomarginal artery. And now we start thinking about subcortical stimulation, looking for the corticospinal tract, how close we are, 3 to 5 milliamps, we stop, as we are doing right now. So this is not based only on anatomy, but also on functional response intraoperatively. And after surgery, you can much better see the cingulate sulcus, the superior frontal sulcus, and the interhemispheric fissure. Another tumor very similar to this one, I will skip this one, but this is a very strange one, pre-post-central gyrus glioma, which was quite tough. The patient, he was 15 years old indeed, and he had an intratumoral hemorrhage, bleeding, and had some hemiparesis. And after decompressing the tumor, the paresis quite improved, just resecting the main bulk of that tumor, which is not common. Usually these tumors in this area destroy the tracts, but as you saw in the tractography, that one was pushing the corticospinal tract quite anteriorly. So it's mainly involving the post-central gyrus, which is number 3. So this is what I try to do. I try to do this work preoperatively and try to imagine where the tumor is located. So this is post-central, this is pre-central, this is the central sulcus. And as you can see, the post-central is the main part of that tumor. So this is the vein I want to find in surgery and translating it to the operating theater. I can see this vein of Trollard, which is located in the central sulcus, just separating the pre from the post-central. So what I do in this case, I start as far as possible from the pre-central gyrus in the posterior part of the post-central. Now moving anteriorly, in the depth, we start doing subcortical stimulation, and we stop in the moment in which we find response at 3 to 5. We can correlate cortical and subcortical. This is the depth of the central sulcus. I stimulated, checked that there was no response, so kept going. That was very challenging because the patient had some paresis before, so it might be confusing, the result of the intraop mapping, but this is what we had to do. Low-grade glioma, you cannot see the tissue quite different. And this is the most anterior part where we had this corticospinal tract, and we stopped the resection there. So let's move a bit more posteriorly to the post-central gyrus, and brain mapping can be also very helpful, as we said before when we were discussing with Tom and Eduardo. It can be very useful to identify the location of a tumor. So this is the central sulcus, this is the post-central gyrus, pre-central gyrus. And this is where the tumor is located intraoperatively. And here we should have the central sulcus, and we should have anteriorly the pre-central gyrus, but brain mapping can help us to identify that in between 3 and 4, we have that N20 wave inversion, and we can nicely locate our MEP grid in the direction of the pre-central gyrus. We keep it with some cottonoids just to avoid its movement during surgery. And this is one of the good things about brain mapping. It's not only useful to extend the resection, but also to decide where to start the resection in. Another case, interesting, I met this patient in 2017 with this 3 times recurrent low-grade glioma in the pars opercularis and pre-central gyrus. So you can see how the tumor is occupying the posterior limb of the pars opercularis and the pre-central gyrus. So we will see that intraoperatively, and we can even see that tractography. This is not quite common. Even we have some tracts, DTA tracts, in the most superior and posterior part of the tumor itself. So this is an area that I don't like to touch unless the cortical, subcortical stimulation is negative. So this is where the glioma is growing. It's not only pars opercularis pre-central, but also, as you can see, it's invading the insula, superior aspect of the insula, through the extreme capsule, which is the connection in between not only gyri of the insula, but also the insula with the subopercular surface. So this is the brain mapping I did. Blank means nothing. 2 means tumor with positive response. 3 and 4 is post-central gyrus with positive motor response. Quite strange in this case. This so-called brain plasticity could be the responsible, but I'm not sure about that. There is no science behind. So in an adult patient. Stimulating and mapping the most anterior part in pars opercularis. So we are doing a literally transopercular resection because the tumor is in the operculum itself. So removing the operculum, you can see the low grade. We reach the insula. Here we have the insula, and this is the superior limiting sulcus of the insula. We extend the resection, and this is superior and inferior trunk of the MCA. Now moving to the most eloquent part, which is the posterior and superior area. And now I start resecting with CUSA and stimulating with the other suction pipe. So in the moment in which we have positive response, we stopped the surgery right there. So again, cortical, subcortical stimulation, super helpful, not only to extend the resection, but also to identify where to go through and where to start with. Case 5, this is a patient in which we have this very similar location in the right side, hemisphere, bilateralized language by a functional MRI, so broca on both sides, pars opercularis, pre-central gyrus tumor. Again, patient completely intact at tapping and token and Boston tests. So this is what we do preoperatively. This is the DI where we have the corticospinal tract. Here we have the IFOF and the arcuate with the SLF. So we can see that the tumor is just very in close contact with the SLF3 and the corticospinal tract. Here we start the awake surgery with deep sedation. Propofol is injected, and we have this laryngeal mask, deep anesthesia, sedation, 40-50 in the bispectral index, and then we start blocking, getting lines, monitoring, scalp clamping. So this is the moment in which we create some pain, but the patient is under sedation. So we inject, as you can see, not only block, but also the pins of the Mayfield. Now, very important positioning of our setup. I use a kind of semi-sitting positioning in these cases, not because of my comfort, but because of the comfort of the patient and the anesthesiologist. This is a bit uncomfortable for the surgeon, but it's very, very comfortable for everyone else in the OR. Neurophysiologists, anesthesiologists, and even the patient are much more comfortable. Now we start preparing the skin with the approach. The patient is still with the laryngeal mask. We open as much as we need. In this case, we want to identify the temporalis muscle, and as the patient has to speak during surgery, this is the kind of incision I'm doing in the temporalis muscle, something like a T-shaped incision, which looks more convenient in these kind of cases, so they don't feel uncomfortable while speaking in the OR. Now we do the bar hole, and now the anesthesiologist starts stopping sedation and medication. And when we expose the dura, patient should be fully awake. I inject temporalis muscle, and I don't inject anesthesia in the dura, but I use this cottonoid with local anesthesia on it. Now the patient is awake, so we start opening the dura. And something I learned is that the dura is painful, so don't use bipolar in the dura. You can just clamp a little bit with a mosquito, those vessels, and the bleeding stops without pain, creating pain to the patient or something uncomfortable. And now we take the mosquitoes out, we expose what we were expecting to find. So you can see the precentral gyrus, pars opercularis. So we expect to find some motor speech arrest in that area. And this is the beauty of working with a fantastic team. Even the patient is extubating himself. That's excellent to have the best team around with you. Now with the ultrasound, we check our boundaries. This is the plan I did before surgery. These are the areas I want to stimulate. So I want to check interpretively. And this is the area in 1 and 2 where I expect to find some speech arrest, and we found, and in points 8 and 9, this is the subcentral gyrus. Maybe we are expecting to find some motor response there. So we start the stimulation. We think also about subcortical. So we decide where to go. Tapping test. Now we are checking, and we are checking that the glioma itself is not responding to cortical mapping. So we cover with cottonoids the areas in which we found response. And now we coagulate, as we said before, the center of the gyrus and start doing our subpial resection, expanding the resection of the glioma circumferentially towards the sulcus. So in this case, we will expect to find the precentral sulcus and maybe the diagonal sulcus, and posteriorly we will find the central sulcus. So now we have a free conversation with the patient looking for the SLF3 right there. We start stimulating with the CUSA, which is electrified. It's a little bit dizziness, and we have to stop a little bit because otherwise the stimulation is not gonna be very accurate. And once we are happy with the result regarding the stimulation on the speech, we can, if the patient is not comfortable, to slip him back in order to deal with the corticospinal tract, because this is something that we can do with the patient sleeping. And as Tom said, this is something we cannot be aware of during, even with cortical and subcortical mapping. This long perforator ischemia, which caused a transitory dysarthria to the patient, which luckily was transitory. But this is something that we cannot even deal with, even if we do the best cortical and subcortical stimulation. Insular glioma, very helpful, pure insular glioma, pushing, as you can see, the operculi out of our surgical field. Important to identify, especially in the most posterior and superior part of the tumor, that we have the arcuate and we have the corticospinal tract. So we can do our mapping, and once we are checking, we are getting this posterior part, we start stimulating. So insula, If we remove the insula, we find the internal capsule. So this is the ventral stream with the IFOV. This is the arcuate in the dorsal stream, and this is the internal capsule. These are the tracts which are very important to be considered during the subcortical resection. So this tumor has split the sylvian fissure for us. So just cutting a little bit the arachnoid, we can see the glioma appearing already there. So again, we leave the most posterior part for the end of the procedure, and we start debulking. And once we are getting posterior in that area, we start stimulating, looking for the corticospinal tract. And that's the point in which we stop our section. And this is the classic post-op of a glioma, insular glioma, in which I have this remnant very close to the posterior limb of the internal capsule, and I prefer this small part remaining there rather than having a hemiparesis. Let's skip this one. This is very similar. This is an insular glioma, but it's invading the operculi. So this is why we can use, in this case, nicely the transopercular approach, because the glioma itself is not only in the insula, but also in the pars orbitalis and in the temporal pole. So we can use these two entries in order to do our transopercular resection. So this is terional. We open the dura. We start removing the superior temporal gyrus. This is the insula from the inferior surface. This is the head of the hippocampus and the amygdala. This is P1 and P2, which means that we have done a complete resection of the anterior part of the temporal lobe, including the amygdala and the hippocampus. And this is the insula itself. So now we go to the pars orbitalis and do exactly the same, trying to communicate both cavities. So let's skip this aspect, and at this point we have a diminishing of the motor response on the MEPs, and we were not close to the internal capsule, so we were thinking that maybe it was vascular. So we use ICG, and this is very interesting to see how this superior trunk of the MCA was blocked. So there was a vasospasm in that area. So we are just using nimodipine and touching a little bit the vessel. You can see how it's responding. So now we are using nimodipine on the cotonoid. And after 10 minutes, we were very lucky, and the patient was even more lucky, that the motor response started increasing again. This is the post-op where you can see a small, very small infarct of one of lenticular striate artery, which is very, very, very relevant. But in this case, luckily, it only caused a kind of dysesthesia to the patient, but not motor deficit. Very challenging pleomorphic xanthoastrocytoma. I want to show you this one because this is super rare. We had this recurrency after 10 years of a pleomorphic xanthoastrocytoma located in the posterior insula, but then appeared a second tumor on the other side of the corona radiata. So you can see two different tumors separated by the corona radiata and internal capsule. So we were thinking that maybe the posterior transinsular was gonna not be a good idea because we have the corticospinal tract there. So we started with a transsylvian approach for the most lateral tumor. This is the previous surgery, a little bit uncomfortable due to the scars. And you can see the posterior sylvian point, trying to dissect it and to localize where the tumor was located. Ultrasound is very, very helpful, and you can see the tumor right there. And as I was removing progressively that tumor, I was doing subcortical stimulation and checking that I had some space to go through here, because motor response was quite anterior, but I didn't find motor response posteriorly. So I decided to go through the corona radiata and to enter this area to try to reach this other lesion, which is right here. But due to the limiting and narrow space, I couldn't remove it completely, and I left this part of the tumor. So we decided 2 weeks later to go interhemispheric, which was the first part. So you can see how this tumor was located. The first tumor here, and the second one in the thalamus. And I crossed the most posterior part of the internal capsule in the first surgery. So this is the interhemispheric transcallosal, in which we were able to reach this most medial part of the tumor. Visual areas are, for me, super interesting. This is a low-grade glioma located in the parietal lobe, but quite close to the optic radiations. And I'm very lucky to work with the bioengineering department, and they are developing some new tools for intraoperative mapping of the optic radiation. So in this case, we decided to test subcortical mapping with the patient sleep and locating an electrode, subdural electrode, as you will see. So this is the one we use for epilepsy, but we were doing our mapping because the patient was having seizures. I wanted to check if there were some spikes. And now we are locating these electrodes towards the occipital pole and towards the precentral gyrus. So with the precentral gyrus one, we are checking MEPs. And with the occipital pole one, what we want to receive is this stimulation. With bipolar stimulation in the depth of the tumor, we can detect if we are close to the optic radiation. So this is the atrium, and we were quite close to the optic radiations. We can see the ependyma now, and now doing bipolar at 10 to 12 milliamps, which is the current threshold which is accepted for optic radiations, we could find response in our electrode located in the occipital pole. So that's the moment in which we decided to stop surgery, and the ultrasound was showing that we were very close to the atrium, which means that we were indeed in the optic radiations, as you can see in the post-op scan. Let's skip this one, in which we did exactly the same, but with the patient fully awake. So what we did is a kind of intraoperative campimetry. So as we are going deep into the tumor, we started stimulating. This is the atrium completely opened, and we are trying to identify where the optic radiations are, if they are superior, inferior, or if they are superior and inferior. He's describing that once I was stimulating the optic radiations, he was perceiving a kind of shadow, no phosphines, no blurry vision, only a kind of shadow. So we were literally blocking, as it is expected, the optic radiations transmission. So this is the post-op MRI. And last case I want to show you, it's a very fresh project in which I'm working. We can also not only do mapping, brain mapping intraoperatively to try to respect the function, but also to try to improve our function. And I am very lucky to be involved in what we call the CorTVS project, in which we are recruiting volunteers to implant a kind of occipital bone electrode, which is called the Utah electrode. It's very thin. As you can see, it's 4 per 4 millimeters. We have 100 poles, and we are inserting this one into the occipital of blind volunteers. This is Berna, the first volunteer in which we implanted this electrode, and it has been slightly designed to reach the layer 4 of the occipital cortex, of the visual, primary visual area. So this is the electrode, and this is how we choose the most appropriate location for the electrode. So we do transcranial magnetic stimulation, and the area in which we get more phosphines, more positive points, is the area in which we want to implant the electrode. We do that with the autoguide, the robotic system, and the navigation. We choose this point here, and we try to implant it, and then it's going with 100 wires to this connection, which is external, so we can register and stimulate at the same time. So you can see the 100 poles, the action potentials of the neurons in the layer 4C. So what these patients are perceiving after weeks of training are phosphines, movement, colors. For example, this combination of electrodes is creating this green line. So we are encoding and registering all this information in a kind of library, which is a hardware. So then, in the second part of the project, with these glasses, when the patient is looking at a wall where there is a green line, the library looks for this result and finds the proper stimulation. So it's being sent to the cortex of our volunteer. This was the first experiment, the stimulation, in which she was able to see black, white, which was something unique. This is the first time that you can see the glasses were very homemade at this time. This was a webcam inserted. And after 5-6 seconds, she's able to map the screen and to identify where is the black square. After months, we have something like this, in which we are asking our volunteer to map, to enter a room, to map it, and to find his mobile phone. And as you can see, this is taking, it's not like our vision, which takes milliseconds. This is taking 6 to 10 seconds to map completely the room and to find the black spot. This is our last volunteer, who is very, very fan of soccer. He was looking for the ball, and once it was identified, he was looking for the people in front of him and to send him the ball. So that was quite nice to have exactly the same experiment. Now he's more confident, looking for the person in front of him. Nobody believes that this is a blind volunteer. So now he's
La tarea es coger la
looking for the cap. So you can see how he's mapping, and the information is going directly to the occipital cortex.
Ahora coge la cuchara y ponla en la taza.
Spoon. Now he's moving through a room just to find obstacles. That's it. And with this, I will finalize. I don't want to bore you more. It's a lot of time what I'm taking. And I want to thank you again for the invitation. It was fantastic. And I want to thank all our volunteers of this last project, which is something that I'm very happy to be. Thank you.
It was very exciting talk, and the finale was even more exciting. It's really sort of amazing to be able to restore lost function. I wanted to ask with these patients, what's our sort of criteria? You know, are these patients who perhaps were born blind, or patients who have lost their vision later on? And could you enlighten us a little bit about it?
Sure. So I just wanted to share it because it's very preliminary. I started working on the project in 2017, and for the time being, I just implanted the 5th electrode 2 weeks back. So it takes a lot of time to find the perfect volunteer. These are not patients, but volunteers, because they need to understand properly that this is not a treatment. This is not restoring vision. They are indeed, I'm explanting this electrode after 6 months. So they don't benefit themselves of it. And the criteria is that, first of all, they understand that. And secondly, general criteria like adults. And of course, we need people who were born with a normal status and lost their vision during life. Why? We do believe that this is going to work in a congenital blind people, but we need them to help us, because this is a kind of training for 2 months, and they need to explain what they perceive. And congenital blind people, they have a completely different understanding of the real world. So that could be done, but we decided to have acquired blind people because of that reason, because the training is much faster. They are teaching us what they see in a much efficient way,
So I was thinking, because who knows what actually is the function of that area of the brain in people who perhaps were born blind, right? So, or have been perhaps not using this area of the brain since childhood or something like that.
Something super interesting is that the last volunteer, we implanted this, she was 63, but she lost vision at the age of 4. And we were registering, not only stimulating, and when she was touching things, her occipital pole was discharging. So she was literally reading with hands with her occipital lobe. And this is something which is not new, I know, but it was shocking to see the neurons discharging when she was touching an object, mapping the object. It's amazing. It's
very exciting.
Sorry, it was not about the topic, but I really wanted to share it with you by the first time.
Nice. And on this acquired loss of sight, not due to cortical lesions, sure, just acquired by the eye or the nerve itself.
Exactly. It's very important that the occipital cortex is completely healthy and intact. So mainly we have people with retinosis pigmentaria, retinitis, advanced glaucomas. And even the last volunteer, he was a soldier in Ukraine war, and he had some bomb and he lost his globes. So it's important to it's anterior to the lateral geniculate ganglia. The lesion should be anterior to the lateral geniculate.
I think Dr. Lorenzo Giammattei had a question or comment.
Yes, I have a question for the speakers. If they can share some tips and tricks to protect the perforators during insular glioma surgery, For example, do they use papaverine, or how long do they stop if something happens to the MIP? Can they tell more about that? Thank you.
If I can start, I think one of the things is, particularly in low-grade glandular surgery, I kind of always work with this in mind, sort of centers that stuck with me by Professor Hugues Dufour. He says the brain doesn't bleed even if Parisian surgeons operate. Apologies for any Parisian surgeons on the call. Essentially, people are very worried about hemorrhage and so on intraoperatively, but this virtually doesn't happen. So bipolar is hardly necessary, as a bipolar as such during glandular surgery. So that's one thing. The other thing is knowing where they are. And Pablo showed the one case with the remnant in the posterior aspect of the insula. So perhaps we're not so worried about the perforators in there, but there are lots of long posterior branches of the MCA that dive into this area. So that's another one. And in the event when things happen, i.e. you see MEPs go down, or the patient while awake stop moving and so on, stopping is very reasonable because vasospasm does happen, and the vasospasm is very something that is very variable among people. I think some people are much more susceptible to vasospasm than others. So getting the blood pressure up helps. Papaverine probably helps as well. It's difficult to say because nobody's done any experiments to say for sure. There's no sort of data backed, but yeah, that's kind of my experience of that.
Did you set a specific protocol for the pressure, arterial pressure with your anesthesiologist, or not really? If something bad happens with MIP?
Yeah, so to answer your question directly, so no, we don't have a protocol. It's kind of trying to in a way be physiologically minded as possible. Often patients are run during anesthesia, particularly when they are asleep. With a lower pressure, anesthesia likes to run them considerably lower than their physiological pressure. So I would, in the first instance, go to the physiological pressure, and in the crisis situation, perhaps even higher, maybe 10-20% higher with the MAP in particular. So that's one. In awake patients a little bit different, but particularly. So I had one event where it happened during the sleep phase. We finished the awake surgery for sort of higher mental function, speech and everything else, and then wanted to complete just at around the internal capsule. So just the motor mapping while asleep, because it was quite a long surgery, and then the blood pressure went down. We often don't realize that because maybe the anesthetist doesn't tell us, but things went down simply because of the blood pressure. Mean blood pressure went down. Sorry, I've spoken to a lot. I'm sure others have their experience to share.
Thank you.
I think Thomas has something to contribute. Do you want to talk about this, or is another question, Thomas?
No, First, I wanted to congratulate the speakers. It's really interesting talks of anatomy and surgery. I think I also learned a lot during these sessions. I just have a question for the panelists. First, what is what would you prefer during awake surgery, the electrified Cusa or the aspirator with stimulation, and what is the threshold? Probably this will be interesting for the audience, that you stop near eloquent fibers, like the motor fibers. Thank you.
Well, just to finish first on the question of Lorenzo about the lenticular striated arteries, just as Tom said, it's better to know where they are before harming them. So you need to have all this anatomical knowledge, but of course studying each case by case, because usually the lenticular striated arteries are displaced to more medially. They are in the depth of the tumor. Once you are at the insula, you begin to see some of the lenticular striated arteries. In my personal point of view, you should stop yourself. You should not go further in of just if you are really comfortable, and because it's to work between the lenticular striated arteries is a very challenging work, and I suppose it's very
I would say mad
so I
rather than
think
challenging.
you should stop yourself. You should hold yourself. Working between the M2 branches, it's feasible. It's the way we do it and Pablo showed a nice case of insular tumor, and that I think you worked of this pure insular tumor, Pablo. One of the cases you showed, I think the patient was asleep, so it was nice to see working between them too. But working between the lenticular striated arteries is much more challenging, much more deep, and I think you shouldn't do this.
I think, Eduardo, you need to be careful saying to neurosurgeon challenging, yeah? Because when neurosurgeons hear challenging, they would definitely try to do that. So you need to say
they
mad.
like the
It's
challenge,
completely
but you
mad.
should hold yourself. And then coming to Thomas' question, I currently we don't have this cannula that continuously has this brain mapping, the high frequency brain mapping, the RAB cannula, right? And I've seen in some congresses how they do not come in many shapes and lengths. And I personally, I learned how to use the aspiration tube with a set of them with different lengths and diameters. So I don't know if I would be comfortable with just one kind of stimulator. But I've seen here some friends in Brazil that are adapting. They take the iron, the metal cannula, old cannula, and they adapt with they have a wire coming from the neurophysiologist, and they isolate with IOBAN around the metal aspirator, and then they can use the old traditional aspirating to map. I don't use it, but I have some friends that do it, and they claim it's very convenient. And how close should you get? I think Pablo said between 3 and 5. Most classical literature will say to stop at 10, but 10 I think it's a little bit far away. I think you should go a little bit more deep, but deeper than 3, I think it's too much. I think Pablo said a good number. Between 3 and 5, it's how do you say, Pablo? Do you think it's a good number?
This is the most well-known milliamps. Usually, regarding also the question from Thomas, I use the regular suction device and the electrified CUSA. Both of them, whenever I'm getting close to mentally subcortical structures, especially corticospinal tract, I start stimulating, but they are really amplifying the response. So I have checked that with 8, 10 milliamps on the electrified CUSA, it means that you are closer than that. So you should check. What I do is I check both. So once I have response with the CUSA, I always go to the monopolar bipolar subcortical classic simulation. And I work with high frequency in the electrified CUSA because of that reason. But always my decision is based on the stimulation, on the monopolar stimulation, always. based on that. It's just the electrified cues and the suction device is just to get an orientation of how close we are getting in the different areas we're doing the resection.
Yeah,
and for optic radiations, it's 10 to 12 milliamps, what I have been checking. There are only 3 papers on that, sorry, and it's for optic radiations, 10 to 12 milliamps. It means that you are getting close.
Yeah, that makes absolutely sense. The other thing is, often things are kind of more nuanced, right? Because it's good to have a rule of thumb, how many milliamps and so on, but it is sort of different in different areas of the brain, different part of the cortical spinal tract, corona radiata, the fibers are a little bit more widely positioned, whether the closer you get to internal capsule, the dense they are. So the effects and also the feedback means slightly different thing. Also, the tumor can be different. Sometimes you have you're essentially working within the normal brain. It's one thing. If you have pure tumor, it's another thing. So one has to always remain very vigilant, sensible, and nuanced.
Another
And also,
interesting
it's different if you go perpendicular to the likely course of the fibers versus tangentially or even in parallel. That depends your direction of dissection. I always do and also train people when they use either Saka or in particular ultrasonic aspirator, not to use it perpendicular to the resection cavity, and even less so perpendicular to the expected trajectory of the fibers that you're concerned about.
Yes. Another interesting 2 cases that you showed, Pablo, lesions at the SMA. These are very frequent lesions, and you showed 2 nice cases. Do you do them awake or asleep? And because they are likely to have SMA syndrome, and some people will do them awake or feel comfortable to do with the patient asleep. What is your main
I do them
view?
asleep.
Asleep.
100%.
Yeah, I figure out.
My point is that it's very, very common that they experience deficits during, and indeed it's not only quite an epileptogenic area, but also they experience deficits during surgery, even in areas in which you don't expect to have damaged. Obviously, the corticospinal tract, especially if we work quite anteriorly. And I personally prefer to feel more comfortable myself and not to stress myself, because, for example, the patient I showed you, the first one, the case number 1, he had SMA syndrome during 5 days. Very, very strong SMA syndrome. So, but finally he recovered, as it's quite well known. After a couple of weeks, he was completely normal, came to normal. So I prefer to base my resection on the anatomical key points and running posteriorly to the corticospinal tract just with subcortical stimulation and asleep conditions. But I have seen many very good surgeons, fantastic ones, doing them on awake, and they work very nicely. So.
We have one question from the Q&A chat here. I think it's here. It's someone from Colombia, Dr. Gabriel from Colombia, and he's asking us if since we are doing brain mapping and neuromonitoring, if this can diminish the necessity of knowing neuroanatomy. And I think I can answer right away. Of course, no, neuroanatomy is the only way to feel comfortable during surgery. And a lot of technologies will be present for us. And I think in years from now, we'll have even more technology. And maybe one technology will be replaced by the other. But non-neuroanatomy, the knowledge that you have to be comfortable during surgery, to understand the situation and to adapt yourself to anatomical differences and brain shift, and even a lot of patients cannot be operated awake. They are not good candidates. There are a lot of patients with a lot of deficits already, or patients that will not comply with the operating theater. They need to be calm. They need to be a good candidate. So I think awake surgery, of course, it's very good, but it's not good for everyone and not good for every lesion. So as you just saw, Dr. Pablo commenting, some gliomas, he will do them asleep. I will do them asleep as well. And so I think neuroanatomy, it's still fundamental, of course.
If I may comment about it, it's ultimately, brain is about function, and our surgery needs to be about preservation of function. And you need to optimize, and then the word optimize is important, optimize your feedback at surgery to maximum. Yeah. So if you can have cooperative patient that is comfortable, you have the right tests, the right readouts, either electrical or functional. This is optimal. There's no question about it in terms of surgery. Then you can be as aggressive as you can because you have proper feedback about what's going on. But it is easier said than done. So as Pablo said, unless the patient is genuinely comfortable and you getting the feedback that you think you're getting, you may actually get confused feedback and end up with very little resection and neurological deficits. So I hope this answer makes sense. There's Dr. Maldonado who has a hand up.
Yeah, thank you, Tom. First of all, let's say a word about how I'm happy to see all you guys together today. It was a wonderful webinar. So really congratulations. And so Eduardo, and also saw Professor Guilherme. It was a special pleasure to see Professor Guilherme today, because he will always also influenced my my way of looking at the brain and understanding anatomy. And so hello to everybody. Well, it was a great webinar, a nice combination of sulcal anatomy and white matter and mapping application. So I would like just to say a word on this last comment from the audience. Is well, I think that my personal view, I cannot imagine brain mapping without anatomy, without a good metal imaging. I think one of the most stressful experiences I had during brain mapping was not knowing where I was. Negative mapping is a really strange, awkward experience. When sometimes you do recurrenotomy, it's smaller or is not exactly the same, the right place, and then you put your electrode and don't get the answers you're expecting for. It's really strange. And other thing is when you get the response for your mapping. I see people saying, okay, I got this response and this response, so I should go here and there. So this is one way of thinking, but I think that's the, I would say, a better way of thinking is, okay, I got that response, and even if I am in an amorphous area of the brain, I cannot see fasciculus, for example, I know which structure is there. So I'm importing that information about the mapping response into my internal anatomical image. You understand what I mean? And this is extremely important because, well, we are studying, with sulcal anatomy and white matter anatomy and vessels. There were beautiful lectures today, and I think there was a beautiful in these webinars that it was that we were putting everything together. And this is let's say the history of this anatomy is still ongoing. We're building this. 15 years ago, 20 years ago, we didn't talk about white matter and subcortical mapping as we're doing it today. And now what we're doing is putting everything together: the sulci, the gyri, and the fasciculus, and the responses. And now we're twisting everything because, okay, we understand that anatomy, and then we go to your OR, and what you see your OR is usually a small part of it through the acroanatomy, and it's not in anatomical position. It's upside down, with rotating. So you need to twist it so you need that mental image. If you don't have that mental image in order to allow you to do those anatomical relationships, I think it's not that comfortable. So I think that against that awkward feeling you can have when you do not navigate properly, or when you feel lost, or when you want to avoid complication, the best protection possible is knowledge, is anatomy. That's the only word I'd say.
Can't agree more. You may be familiar with the saying by Warren Buffett, the financial investor, who always used to say, the risk come from not knowing what you're doing. So really, the way to minimize risk is to maximize your knowledge, and I suppose that's why we've been having the seminar today.
Okay, people, I think we can wrap up. It was great to have everybody here. We have about 50 people, and it's on the next seminars, stay tuned for our next meeting, because we are going to come from the superficial lesions toward the deep regions of the brain. And our plan right on is to have one each month approximately, and we'll now organize the next one.
Perfect. Thank you very much for all tuning in. Thank you, Eduardo, for sharing, and special thanks to all those who tuned in and our speakers who entertained us today.
Thank you. Thank you, you all. Pablo,
you.
Thomas,
Thank you. Bye.
I saw Lorenzo also, Toma, and
Bye-bye.
all the people that is here. Thank
Bye.
you.
Pleasure.